Chapter 1 allows us to take a closer look into drug action. When we consider how drugs operate and function in the body, we must consider three dynamic phases: pharmaceutic, pharmacokinetics, and pharmacodynamic. So let's take a look at phase number 1, pharmaceutic. In the pharmaceutic phase, the drugs become a solution so that they can cross the biological membrane. The pharmaceutic phase itself is broken up into two additional phases called disintegration and dissolution. Disintegration is the breakdown of a tablet into smaller particles. Dissolution is the dissolving of smaller particles in the GI fluids before absorption can take place. So for example, approximately 80% of all drugs are taken by mouth. The drug in solid form must disintegrate into small particles to dissolve into a liquid. This process is called dissolution. However, when we consider taking medications with enteric coating, these drugs resist disintegration in the gastric acid of the stomach. So disintegration does not occur until the drug reaches the alkaline environment of the small intestines. So it's important for us to remember that medications must be dissolved or transformed from a solid to a liquid state. However, when drugs are in a liquid form, they are already in a solution state and bypass this pharmaceutic phase altogether and move directly into the next phase of action, which is called pharmacokinetics. Pharmacokinetics is the process of drug movement to achieve drug action. The four processes are absorption, distribution, metabolism or biotransformation, and excretion or elimination. It's important for nurses to take that knowledge of pharmacokinetics to assess our patients for any adverse drug reactions. We need to also apply that information and communicate it with all of the healthcare team to ensure that we are safely administering medication as well as assessing for the effectiveness of the drug therapy for the patient alone. When we think of absorption, it is the movement of drug particles from the GI tract to body fluids by passive absorption, active absorption, or penocytosis. Oral drugs, as stated before, are absorbed in the surface area of the small intestines through the action of the intensive mucosal villi. Absorption is reduced when there is a problem with the villi, and it's decreased in number because of a disease process, some type of drug effect, or the removal of the small intestines alone. Many drugs go through this process of passive absorption, mostly by diffusion. Basically, it's moved from a higher concentration to a lower concentration. Whenever we're thinking of pathophysiology and you're thinking of osmosis of water, this is the same concept in regards to how drugs are being diffused throughout the body or across the membrane itself. The key thing that we have to remember with passive transport is that it does not require any energy in order for this movement to take place across the membrane. However, with active transport, it requires a carrier such as an enzyme or a protein to move the drug against a concentration gradient. Energy is required for the active transport. And when we're thinking of penocytosis, it engulfs the medication itself and helps transport the drug across the membrane itself. As we continue to look at absorption, it's important for us to remember that the GI membrane is mostly composed of lipids and proteins. So drugs that are lipid soluble pass rapidly through the GI membrane. However, water-soluble drugs need a carrier, either enzymes or proteins, to pass through the membrane. important for us to remember, just as we just discussed, these medications, especially water-soluble medications, are active, transport through an active process or penocytosis. So let's also consider large particles passing through the cell membrane if they are non-ionized. Weak acid drugs such as aspirin are less ionized in the stomach, and they pass through the stomach lining easily and rapidly. So remember, drugs that are lipid soluble and non-ionized are absorbed faster than water soluble or ionized drugs. Let's look at the next concept called first pass effect. Some drugs do not go directly into the systemic circulation following oral absorption, but pass from the intestinal lumen to the liver via the portal vein. In the liver itself, some drugs may be metabolized to an inactive form that may then be excreted, then reducing the amount of active drug. Some drugs do not undergo metabolism at all in the liver, and others may be metabolized to drug metabolites, which may be equally or more active than the original drug. This process in which the drug passes to the liver first is called the first pass effect, or the hepatic first pass. So it's important for us to make sure we understand most drugs are given orally or affected by the first pass metabolism. Lidocaine and some nitroglycerins are not given orally because they have extensive first pass metabolism, and therefore most of the dose would be destroyed. So the idea of first pass effect, medications are metabolized to an inactive form and sometimes undergo or lose the effectiveness of the drug itself whenever they are metabolized by the liver itself. Moving on to the next concept, bioavailability is a subcategory of absorption. It is the percentage of the administration of the drug dose that reaches the systemic circulation. For the oral route of drug administration, bioavailability occurs after absorption and first pass metabolism. The percentage of bioavailability for the drug route is always less than 100%, but for IV route, it is 100%. So again, going back to the first pass effect, medications that are metabolized by the liver will lose its effectiveness, and basically the strength will be decreased because it's metabolized by the liver first, broken down into a less or inactive form of the drug. So affected by the drug form is basically the route of administration, the GI mucosa or motility, different types of foods, other drugs, and changes in the liver metabolism caused by a liver dysfunction or inadequate hepatic blood flow. So it is very important for us to make sure that we understand when we are assessing our patients, what exactly are we assessing to understand if our liver is functioning properly. It would be the liver function test. We would make sure that the liver is functioning properly and our patient's not exhibiting any signs and symptoms of decreased hepatic blood flow. If you pay attention to this illustration here, it will show you the difference of ionized proteins or ionized drugs with lipid-soluble drugs that are moving across the membrane and that may require an active or passive transport. So this is just an illustration that will show you what protein binding and drug distribution could look like. So go back to table 1.1 and table 1.3 in your text to understand and look at the half-life of the medication, as well as looking at how medications are being transported throughout the body. It gives you an illustration that will show you this drug distribution as a whole. This is another example of distribution of medications, but this time across the placenta. Pharmacokinetics, as we can continue this process of understanding how drugs are being metabolized in the body, it's important to remember that metabolism is the process by which the body inactivates or biotransforms drugs. Drugs can be metabolized in several organs. However, the liver is the primary site of metabolism. Most drugs are inactivated by the liver enzymes and then converted or transformed by hepatic enzymes to inactive metabolites or water-soluble substances for excretion. The half-life of a drug is the time it takes for 1/2 of the drug concentration to be eliminated. Metabolism and elimination affect the half-life of the drug. The kidneys are responsible for elimination. In order for us to determine proper kidney function, we look at the GFR. With the kidney disease, that results in decreased GFR, or glomerular filtration rate. GFR is the best way to determine proper renal function. However, it's very expensive. So what is normally and the most common test is the creatinine clearance test, and the BUN, or blood urea nitrogen test. Not only is the drugs responsible for excretion or being excreted by the kidneys, but the liver also helps with that process of excretion, as well as feces, as well as lungs. When we're thinking of feces and our patients are taking medications, as stated before in other discussions, we have to make sure that we always assess our patients' ability to break down or eliminate a drug and assess proper GI motility. And if a patient is constipated, we know that sometimes some drugs may alter the effect of the patient being able to excrete it from the body. The lungs are responsible for acid-base balance and also removing waste from the body at the same time. Pharmacodynamics is the study of the way drugs affect the body. Drug response can cause a primary or secondary physiological effect, or both. When we're considering a primary effect, it is the intended or desirable effect of the medication. When we are considering medications that have a secondary effect, it may be something that is desirable, or it may be something that isn't desirable. For example, of a drug with a primary and secondary effect is Benadryl. Benadryl is antihistamine. The primary effect of the medication is to treat the symptoms of allergy, and the secondary effect is the central nervous system depression that causes drowsiness. So the secondary effect is what is undesirable. When a patient drives a car, but at bedtime, it can be desirable because it causes mild sedation. One important aspect of pharmacodynamics is knowing the drug's onset, peak, and duration of action. Onset of action is the time it takes to reach the minimum effective concentration after a drug is administered. Peak action occurs when the drug reaches its highest blood or plasma concentration. Duration of action is the length of time the drug has the pharmacologic effect. Please look at the illustration in Figure 1.6, as it illustrates the areas in which onset, peak, and duration of the drug occur. Some drugs produce effects in minutes, but others may take days or even hours in order for the effect to be produced. Drugs act through receptor sites by binding to the receptor to produce or initiate a response or to block or prevent a response. The activity of many drugs is determined by the ability of the drug to bind to a specific receptor. The better the drug fits at the receptor site, the more biologically active the drug is. It is similar to that of the fit of the right key in a lock. Use the illustration in figure 1.7 to visualize a drug binding to a receptor site. If we're to refer to the antagonist and agonist effects, drugs that produce a response are called agonists, and drugs that block a response are called antagonists. Epinephrine stimulates beta-1 and beta-2 receptors, so it is an agonist. Atropine is an antagonist. It blocks the histamine receptors, thus preventing excessive gastric acid secretions. The effects of an antagonist can be determined by the inhibitory action of the drug concentration of the receptor site. Many agonists and antagonists lack specific and selective effects. A receptor produces a variety of physiological responses, depending on where in the body the receptor is located. Cholinergic receptors are located in the bladder, heart, blood vessels, stomach, bronchi, and eyes. A drug that stimulates or blocks the cholinergic receptors affect all anatomic sites of location. Drugs that affect various sites are non-specific drugs and have properties of non-specificity. Drugs may act at different receptors. Drugs that affect various receptors are non-selective drugs or have properties of non-selectivity. For example, Thorazine acts on norepinephrine, dopamine, acetylcholine, and histamine receptors, and a variety of responses result from action at all these receptor sites. Epinephrine acts on the alpha-1, beta-1, and beta-2 receptors. If you look at figure 1-9, alpha-1 is going to totally stimulate or affect the blood vessels. So if you're thinking of beta-1, it's going to affect the heart, how it increases. So beta-1, one heart. Beta-2 will affect the lungs or the bronchia. It's going to relax the bronchioles. So an easy way to remember is beta-2 to lungs. These drugs produce a response but do not act on a receptor, may act by stimulating or inhibiting enzymes activities or hormone productions. As we continue to look at pharmacodynamics, we'll look at several different categories of the drug action. The 4 categories of drug action include stimulation or depression, replacement, inhibition or killing of organisms, and irritation. In drug action that stimulates, the rate of the cell activity or the secretion from a gland increases. In the drug action that depresses, cell activity and function of a specific organ are reduced. Replacement drugs such as insulin replace essential body components or compounds. Drugs that inhibit or kill organisms interfere with bacterial growth. So therefore, penicillin exerts its bactericidal effects while blocking the synthesis of the bacterial cell wall. Drugs also can act by mechanisms of irritation. Laxatives irritate the inner wall of the colon, thus increasing peristalsis and defecation. The safety of drugs is a major concern. The therapeutic index estimates the margin of safety of a drug through the use of a ratio that measures the effectiveness or therapeutic dose. 50% of people and lethal dose in 50% of people. The closer the ratio is to 1, the greater the danger of toxicity. The therapeutic range of the medications or therapeutic window of a drug concentration in plasma is the level of drug between the minimum effective concentration in the plasma for obtaining desired drug action and the minimum toxic concentration, the toxic effect. When a therapeutic range is given, it includes both protein-bound and unbound portions of the drug. If the therapeutic range is narrow, such as for digoxin, the plasma drug or level should be monitored periodically to avoid drug toxicity. As we continue to assess or review the pharmacodynamics of medications, it's important for us to also look at peak and trough levels, the loading dose of medication, side effects, adverse reactions, and toxic effects, pharmacogenetics, placebo effects, and tachyphylaxis of medications. Peak and trough levels are serum levels that are evaluated by healthcare providers, particularly nurses, prior to administering medications that have a very narrow therapeutic index and can be considered to be toxic, such as aminoglycoside antibiotics. Peak drug levels indicate the rate of absorption of the drug, and the trough drug levels indicate the rate of elimination of the drug. If either the peak or trough level is too high, toxicity can occur. If the drug is too low, no therapeutic effect is achieved. Peak drug level is the highest plasma concentration of the drug at a specific time. Peak drug levels indicate the rate of absorption, as we stated before. If the drug is given orally, the peak time might be 1 to 3 hours after drug administration. If the drug is given IV, the peak time might occur 10 minutes. If a peak level is ordered, a blood sample should be drawn at the proposed peak time according to the route of administration. The trough drug level is the lowest plasma concentration of a drug, and it measures the rate at which the drug is eliminated. Trough levels are drawn immediately before the next dose and is given regardless of route of administration. It's important because nurses tend to draw the peak and trough levels. The peak is usually 1 hour after administration, and the trough level is 30 minutes prior to administration. Is whenever the serum levels are being evaluated. When immediate drug response is desired, a large initial dose, known as the loading dose of a drug, is given to achieve a rapid minimum effective concentration in the plasma. After a large initial dose, a prescribed dose per day is ordered. For example, in the case of digoxin, usually an initial loading dose is prescribed for the medication prior to giving a maintenance or daily dose of the medication. It requires digitalization is the process by which the minimum effective concentration level for digoxin is achieved in the plasma within a short time, which is why it needs a loading dose prior to the maintenance dose of the medication that will be required on a daily basis. Side effects are physiological effects not related to desired drug effects. All drugs have desirable or undesirable side effects. Even with a correct For example, at bedtime, when its side effect of drowsiness is beneficial. At times, however, side effects are called adverse reactions. Adverse reactions are more severe than side effects. There are a range of unintended and occurring at normal doses of drugs that can cause mild to severe side effects, including anaphylaxis, cardiovascular collapse. Adverse reactions are always undesirable. Adverse effects must always be reported and documented because they represent variances from planned therapy. Toxic effects or toxicity of a drug can be identified by monitoring the plasma therapeutic range of the drug. However, for drugs that have a wide therapeutic index, the therapeutic ranges are seldom given. For drugs with a narrow therapeutic index, such as aminoglycoside antibiotics and anticonvulsants, the therapeutic ranges are closely monitored. When the drug level exceeds the therapeutic range, toxic effects are likely to occur from overdosing or drug accumulation. Pharmacogenetics is the scientific discipline studying how the effect of a drug action varies from a predicted drug response because of genetic factors or hereditary influence. Because people have different genetic makeup, they do not always respond identically to a drug dose or planned drug therapy. For example, African Americans do not respond as well as Caucasians to some classes of antihypertensive medications, such as ACE inhibitors. We know that ACE inhibitors are angiotensin-converting enzymes, which can affect your patient's renal perfusion, or can be affected by the renal functioning. If we are to look at the GFR levels for our patients when we're evaluating our lab values, we know that specifically African Americans have a different level or rate of functioning as in other ethnic groups. So it's important for us to make sure that we pay attention to those associations that are formed when we look at certain genetic factors that may be presenting when we're administering medications to our patients. Tolerance refers to a decreased responsiveness over the course of therapy. In contrast, tachyphylaxis refers to a rapid decrease in response to the drug. In essence, the tachyphylaxis is an acute tolerance. Drug categories that can cause tachyphylaxis include narcotics, barbiturates, laxatives, and psychotropic agents. For example, drug tolerance to narcotics can result in decreased pain relief for the patient. If the nurse does not recognize the development of the drug tolerance, the patient's request for more pain medication might be interpreted as drug-seeking behavior associated with addiction. So prevention of tachyphylaxis should always be part of a therapeutic regimen. We'll discuss this later on as we progress in the course of the A placebo effect is a psychological benefit from a compound that may not be the chemical structure of a drug effect. The placebo is effective in approximately 1/3 of persons who take a placebo compound. Many clinical drug studies involve a group of subjects who receive a placebo. The nurse can increase the therapeutic effect of the drug, but violate the truth-telling ethical principle if the non-therapeutic drug is presented as the therapeutic agent. Hence, it is required that participants in drug trials be told from the start that they might receive a placebo. So to review the phases of drug actions, pharmaceutics, it's important for medications to convert from a solid form to a liquid form in order for it to be absorbed properly into the body. Once we reach pharmacokinetics, absorption, distribution, metabolism, and biotransformation of the medication is essential prior to it being excretion. And of course, the pharmacodynamics is very important because we need to remember, how does the drug action actually occur? What is the particular onset of the medication? What is the peak of the drug? How long will it last in the body? Does it bind to receptor sites, and can it be broken down by enzymes and controlled by hormones? It is crucial for nurses to understand this important phase of drug action in order for us to properly administer medications to our patients in a safe format. So let's look at the nursing process in regards to medication administration. It's important for us to make sure that we take a thorough patient history to identify if there's going to be any problems in regards to pharmacokinetics. If there's going to be an issue, or if the patient has low levels of albumin in the body, then definitely it's going to affect the patient's ability to bind to protein binding medications, right? We also want to make sure in that assessment or collection of history, we identify what can also affect pharmacodynamics. If there's going to be some type of deficiency that might cause the patient to develop anemia, we need to collect extensive medication history, perform our physical assessment, and make sure we identify any side effects that are of the drugs that are not specific, right? For example, if we're going to be given atropine to be administered to the patient, then we're going to assess our patients for what? Tachycardia, dry mouth and throat, constipation, and urinary retention. We're also going to evaluate the peak and trough levels for medications that have a very narrow therapeutic range. It is essential, if the trough level is high, then the toxic effects can result. It's essential for the nurse to know and understand how that works in regards to nursing interventions. Always advise the patients not to eat a high-fat food before ingesting enteric-coating foods, because it tends to affect the rate of absorption. It's going to decrease it. Monitor the therapeutic range of certain drugs that we're going to be giving, because we want to make sure that prior to the administration of the medications, we check to see if the patient has a therapeutic range. For example, digoxin or vancomycin, as we talked about before, or gentamicin. Culture considerations are key. Beware that individuals of some ethnic or racial heritage metabolize drugs differently than other populations. So always assess for adverse reactions resulting from these different or variations in metabolism. And finally, in our evaluation phase, we want to evaluate to determine if the effect of the drug. Is it therapeutic? Have we reached the clinical factors that we were supposed to reach? Is it the proper rate of administration? Is pharmacokinetics being properly ranged? Is it absorbed properly in the body, distributed, metabolized, and even excreted? And are there potential side effects in the body? Will this drug be too free and result in drug toxicity? It is crucial as a nurse to understand how the nursing process will affects or has to be taken into consideration whenever you're going to be medicating your patient.